I think the first component here is, Matt, you talked a lot about finding trusted partners, creating trusted partners. You kind of created, you still had your sort of older school insurance healthcare lane over here, and then you created a whole separate lane. You sort of opted out, right, and created those new partners. Walk me through, and I would love to hear everyone's perspective on this. How do you go about finding those trusted partners when maybe you're 2 for 3 with trusted partners when you had the whiteboard and you wrote everyone there? So I guess from each of your perspectives, I'd be curious, how does everyone in this room, whether you're on that healthcare professional side or on the employer side, how do you go about finding those trusted partners apart from attending the FMA?
Yeah, great question. I was surprised. I mean, just a really fast point on letting the old partners know once I had selected new ones. Not a single one took it well. It was very foreign to them that we would even switch. That this free market notion of, I kind of almost pleaded with them. I tried for like a year plus to get you to be more strategic and so forth, and I'll take you out to lunch, and they all just kind of really got mad at me. The TPA switch tried to sabotage the switch, and so that part is difficult. So I would say just know that going in. Sometimes you can do everything right. It doesn't mean they're going to respond well, right? We don't have to make everybody happy. Sometimes you just have to be respectful and move forward. And then especially on the selection of new partners, probably I would lean more on references and proven performance, right? Show me where you've described this, but show me where you've already done it and how you've done it, and that you are doing it. And because one of the things with whether it be big house brokers or whether it be TPAs or PBMs, I'm not sure I have any words to describe this. I'll say incredibly good. That's not even close to how good I think they really are of selling their product and sounding really good. And they will fool you every time in a sales process. But we have to filter ways through that and really understand if they're being successful at that, and show me examples where you've done it, and then references even outside, right? That conversation would be my answer.
Sinclair Upton once said, "It's hard to convince a man of something when his paycheck depends on him not understanding it." I think the question of incentives is huge here. So you have, as a base level, Matt, you've said in your book, trust is the currency of healthcare reform. And so you have the question of, integrity, good people, but in addition to integrity, what you're going to run into if you have trustworthy people, but working in a poor incentive structure, you're just going to get apathy. They might say, "Hey, that's really cool, but that's not really my problem." And so I'd say the combination of integrity, of trust-based relationships, and then also making sure that this business relationship has the proper incentives such that you combine that trustworthiness with motivation to actually solve this problem together. So for Veritas Surgery, as far as just kind of going to that trust part of it, we do not put a huge emphasis on vanity metrics. Anyone can game vanity metrics. When we're partnering with new surgeons, we are looking to professional and community reputations. And so for us, that looks like talking to the nurses, talking to the physical therapists who see the outcomes, talking to the DPC physicians. And what's really striking is that, patterns evolve. Usually you start seeing triangulation that happens. There's going to be, the same name is going to start popping up, over and over. It's like, yeah, if it was my kid, that's the surgeon I want doing it. And that trumps vanity metrics any day.
Yeah, I'd echo Matt and David's comments, but for me, in our role as a third-party administrator, we and Matt knows this, we have a fair amount of direct business where there is no consultant involved, and that's not always our goal. It's just that some consultants won't play ball with us because we don't play ball by their rules, because they're generally counter to what's good for the employer and the patients. But so the first thing that I always ask, if I'm ever picking partners, if I'm selected and it's my responsibility to pick partners in a benefit plan, my first question is, how do you get paid? Not what you get paid. How do you get paid? Do you get paid? I mean, because we have to understand, and I know we all do this, but healthcare costs are going up. I mean, that's the constant in the equation. And so if you are a vendor in the healthcare world and you get paid on a percentage of spend or a percentage of savings, you can suck at your job and still get a raise every year. So if you do nothing, you'll get a raise, and you'll never have to ask for it. It will just fall out of the trees miraculously. So you want to select a vendor that gets paid on something that is not attached to ever increasing healthcare spend, like a flat per employee per month. Now, we tend to do that per employee per month, and then we like to get bonused if we're able to keep employees happy, healthy, and reduce net spend of the health plan. So I mean, it's all about incentives, and unfortunately, I think Matt or Chris mentioned this. Healthcare is not broken for most of the people that are in the payer buyer side. Healthcare is working just fine. So you are disrupting a gravy train by trying to do the right thing. And you would think that doing the right thing, you would get all sorts of friends and accolades, but you don't. You get into a lot of arguments, and a lot of friendships get severed if you try to rebut the system. So.
Yeah, thank you. So I guess one final comment or a question for you three. So obviously, I think in this room, the majority are healthcare professionals. We've got some imaging. We've got DPCs. We've got everyone from a few different practice types. What is, I guess, what is one way that I think everyone's trying to figure out, how do we work with employers better? How do we get involved in the plans, and how do we provide that? How do we get integrate into health plans and be able to provide for really a more holistic healthcare solution where we're in that self-funded plan? I guess what's one takeaway or one comment you would have to everyone who in this room who I think is trying to do that better and figure out ways to grow that way?
Start.
That's a great question and a very difficult one. It might depend on what you're doing. So direct primary care probably has a little bit easier path than as opposed to specialty care. Primary care, I've seen a rare few even go to fully insured employers and be able to add that on. There's always that cost question. Feels like you're buying two things, but I know one in particular in Madison that had over 20 of those. But most of the time, they don't have insurance, and maybe they'll blend it with a health share or some other alternative method, or if they're self-funded, they can add in DPC with really not too much difficulty. It's not even tied to the renewal cycle. And I always like to say that DPC should replace the cost of where they would have went to the hospital for primary care. It's not necessarily an add in that, but not quite that simple. On the specialty side, we're going to have some, I think, both conversations on this. That's a longer answer, so I'll keep it brief, but that's a little harder because you're out of network. And when we talk about, I would just say as I've designed these plans, I'm in my third time around with the Rise Up plan in Texas, and I've done it before. We have to think of the whole care path. And we're trying to influence the don't feed the beast concept. If they get into the hospital, if we believe that's not as good care, it's not personal, by the way, like we're not against anyone. We're just trying to go for fair cost and great care. But if once they're in, there are cases where you can pull them out if you have live data and you can make a call and say, I can get you this MRI for free or whatever. But for the most part, if we have care paths that keep them out of the hospital and keep them on this new system we're building, the direct care, such as an example might be DPC first. You always want that to be the home base. Everything there in the plans I designed, for instance, are zero cost. Even stitches, crutches, labs, et cetera, all paid by the employer, zero cost, because we know it's fair and very affordable. And let's say maybe there's a heart question. We didn't have any, but now we have, for instance, in Wisconsin, 2 independent cardiologists. You'd say, well, that big deal. Why would I do that if they need, heart surgeries are expensive, but so that's another, well, do they need heart surgery? Let's say they truly need a stent. These independents, by the way, will be more honest with you. They won't automatically say, if you go to a surgeon, what might you get? In most cases, you're going to get a surgery and maybe it really didn't need it that badly, right? These independents tend to be more honest or open or candid and say, you actually don't need surgery yet, maybe PT or wait 5 years or whatever it may be. But the point about the cardiologist then is, I forget who had mentioned it, Jay or someone, about Oklahoma Heart. Well, that's a rare one. I don't have any heart surgeons in Wisconsin, but I could incentivize them to go to Oklahoma Heart. You see how I've influenced that whole care path and kept them out of the hospital. The same could be for DPC to MRI to orthopedic surgeon, but my goal is to keep them in a system that serves them well, that keeps the cost down. But once they're into the system, those docs are required to refer internally, and then the patient loses, the plan loses.
Yeah, I'd also say a cord of 3 strands is harder to break, and there's real strength in all these islands of excellence working together. And I think one of the weaknesses, in business, your good business is solving a real problem at the pain point, a problem that somebody else has that you're providing a solution to. And so I would encourage, various specialists who each represent one piece of the solution to work together to solve the problem where it actually exists. And so, in this room, the two parties who have the biggest problem is the employer who's paying the bills, or the health share who's paying the bills. And so to the extent that you can collaborate with other trusted partners to deliver a comprehensive solution versus just, oh, well, here's my piece of it. I was burned out there, so here's how I changed things. But when you can actually get those islands of excellence together and say, we've all come together and solved this problem for you, that's a lot more powerful. And so there's a lot of ways that can happen. There's marketplaces like Coral and Savos and Fair Market Health. That's one piece of that. Another is, some of these innovative health plans. I'll make an announcement later. We're getting ready to launch one. But really that idea of working together to deliver a complete solution versus piecemeal.
Yeah, I don't have anything to really add to David and Matt's remarks. An integrated care plan is huge, and it best case is it is designed into the benefit plan, and it is part and parcel of the administration. The thing I will say that I would be remiss if I did not say this, because remember, I'm an old crusty TPA, and we usually have to clean up the legal messes that occur with these employers when the DOL comes knocking. Most everything that we've talked about here, we've already said that, the employer really needs to be the buyer, right? So they need to be self-insured or part of a health share ministry, because if it's the insurance company, all these great ideas, they just benefit the insurance company, and you have to trust them to lower the premium, and they're not going to. And so that, I think that could be a temptation for a physician to talk to an employer and say, well, just pay me directly. Don't do that, because it's illegal. So I hope you're hearing what I'm saying, is that, hey, I know you're fully insured or you're self-insured, but you're with a BUCA carrier and they're not willing to play and make things right. Well, how about you just write my practice a check every month? That is actually not a permissible expense for a business. That's taxable income to the participant. And most employers don't realize that. They can buy copier paper and toner for their copier. That's a legitimate business expense under the IRS code, but paying for an employee's health care even through a DPC, is not a permissible business expense. That has to be run through a health plan, or it's seen as regular old taxable income. So that's a whole can of worms. That could be a whole 3-day conference in and of itself. But I just wouldn't be able to sleep at night if I didn't say that, because when physicians hear hurdles, that is the easiest way to get over the hurdle, but it can create a lot of cascading catastrophe for the employer, not for the physician, but it's a great way to ruin your reputation with the employer and the community if you end up getting an employer fined.